Okay, let's continue. I can't even remember where we were. I think I was talking about management of nephrogenic diabetes insipidus. So we said thiazides, NSAIDs, and I was explaining the fact that nephrogenic diabetes insipidus can be caused by certain drugs. For example, lithium. Lithium usually causes nephrogenic diabetes insipidus. So how to treat that? You just discontinue the lithium. Yeah. So next we have this. So results below are for an 83-year-old man in ICU. Calculate the osmolality and comment on the results. Sodium. So you guys tell me. Sodium. Sodium is low. Potassium, normal. Chloride, low. Urea, 4.3 is normal. Glucose, 5.8, normal. Okay, so calculate the osmolality. Calculate the osmolality. Do you know how to calculate it? Yeah, calculate. Give me the answer. Anyone who has calculated? Someone has told me 24 point, 242.5. Yes. Someone else has gotten 234.1. Someone else has gotten 242.5. I don't know how you got to 31.4, but so let me show you the formula. So the formula is 2 times sodium plus potassium. I'm assuming you didn't add the potassium. Yeah, you can usually forget. Sodium plus potassium plus BUN plus glucose. Okay. So this is just basic arithmetic. So 2 into 112 plus 4.2 plus 4.3 plus 5.8, you get 24.5 millimole per liter. Someone is asking, what is BUN? BUN is now here urea. So blood urea nitrogen, which is urea, so 4.3. Then glucose is 5.8. Yeah, so if you're to comment on it, it is low. So low plasma osmolality and hyponatremia. So these are the references. So urine is 500 to 890, plasma is 275 to 90. So if you are asked, what is the pathology? What is this? What is the pathology here from this patient? Answers in the chat. SI, ADH. Syndrome of inappropriate ADH. Okay, antidiuretic hormone secretion. Yeah, so so the hallmark So the hallmark of SIADH is hyponatremia with hyposmolality and high urine osmolality, as we have seen here. Hyposmolality, which is plasma osmolality, and high urine osmolality. Let me write here plasma so that it doesn't confuse. Okay, so I can explain the pathophysiology of SIDH. So before I explain the pathophysiology, what is SIDH? So syndrome of inappropriate ADH secretion. Okay, so this is when you have, it's a condition where the body makes too much of ADH. So if you compare to diabetes insipidus, we said diabetes insipidus is where you have little or no, or you have ADH sensitivity. So that's the difference between SIADH and diabetes insipidus. For causes, who can give me some causes of SIADH that you know of? So think of conditions where you can produce, where you can cause the levels of ADH to increase. So think of, where is ADH produced? So in the pituitary, isn't it? So if you have, let's see the answers. Trauma, yes. So trauma, imagine if you have a head trauma, you know, surgery, yes, surgery is also a good answer. So CNS surgery, a tumor, yes. So the tumor can suppress, the tumor can press on the pituitary, leading to increase in production of ADH, yes. Some drugs, yes. So which drugs do you know? So we have cyclophosphamide. Cyclophosphamide, the mechanism of ADH, I was reading somewhere, basically how it works is it increases the number of ADH receptors. So you can imagine if you have increased number of ADH receptors, it will be more binding of the hormone. Yeah. I'm looking for one condition no one is mentioning. A very common condition. It is a very high yield condition that causes ADH. Yes, paraneoplastic syndrome. I'm sure even Oliver talked about this. Paraneoplastic syndrome. So paraneoplastic syndrome, there is an ectopic tumor. Okay, so ectopic is outside of the pituitary. So it's a tumor. So the paraneoplastic syndrome is a tumor that is producing ADH outside of the pituitary gland. So which one is it? Small cell lung carcinoma. Correct. Excellent. So the paraneoplastic syndrome, and it's associated with small cell lung carcinoma. Yes, very good. That's the one I was looking for. Others, we have pneumonia, we have COPD. Yeah. Okay, that was the one I was looking for. That's good. So I hope you've understood the causes. Now at least we can go to the pathophysiology. So remember, excessive ADH secretion. So whether tumor, head trauma, surgery, whatever. What do we have? Remember, the function of ADH is reabsorption of water. And when you reabsorb water, we have water retention. So water retention is the fact that you're reabsorbing water from the kidney. And when you absorb water from the kidney, we know that extracellular fluid volume, increased total body water. This is true. Two ways. Number one, transient, meaning temporary, subclinical extracellular fluid volume expansion. Okay. This is the ECF. We expect the water to flow, enter the ECF. Okay. Leading to volume expansion. But remember, when we also have volume expansion in the ECF, some will go to the intracellular fluid. Now, this water that will go to the intercellular fluid will now lead to this dilutional hyponatremia. What is this? Dilutional hyponatremia basically means you have the sodium levels are within range, 135 to 145. But what you're doing is you're increasing the amount of water, the amount of plasma, okay? So as much as the sodium levels are 135 to 145, which are within the range, you have increased amount of water. So this is what we call dilutional hyponatremia, okay? So basically the sodium is distributed in a large pool of water, okay? That's dilutional hyponatremia. I hope you've understood that. So this one will eventually lead to euvolemic hyponatremia. So for euvolemic, the classic presentation of euvolemic natremia that you must remember is there is no edema compared to the other ones. Euvolemic, there is no edema. So this is the pathway that I've explained. Then this other one I can explain. So imagine when you increase volume expansion. When you increase the amount of water, what happens? You're increasing the blood volume, isn't it? So when you increase the blood volume, what are you increasing? More volume, more pressure. And when you have more pressure, what happens? Natriuretic peptides. So we know the A and P, we know A and P, we know B and P. So A and P and B and P. B and P is the brain natriuretic peptide. It's actually produced by the heart, not actually the brain. Okay. Yeah. So what are the effects of natriuretic peptides? Vasodilation. And when you vasodilate, what are you doing? You're increasing the size of the blood vessels, and when you increase the size of the blood vessels, what happens to the volume, to the pressure? It will decrease. Okay. Yeah, it will decrease. Yeah. Decreased aldosterone. Decreased aldosterone. Why is the aldosterone decreasing? This is activation of the RAS system. You can imagine we have a lot of water, and we know aldosterone increases pressure, isn't it? But now it's like a feedback mechanism. The natriuretic peptides have caused vasodilation, leading to low volume, and then the aldosterone, the kidney will cause aldosterone production to decrease the pressure. What happens when you decrease aldosterone? Increase urinary sodium excretion. When you excrete more sodium, further sodium loss, leading to euvolemic hyponatremia. And another one, normalization of the extracellular fluid, leading to euvolemic hyponatremia. Okay. Have you understood the pathophysiology of SIADH? Hopefully. What else can they ask? How do you treat SIADH if they ask management? Any answers in the chat? Think of this person. He has a lot of water. What do you do? The most important is management. Yes, okay, loop direct. But what's the first step? So the first step is fluid restriction. You have to restrict fluid, because you can imagine this person has a lot of water. Then you want to cause the person to drink more fluid? No. So you do fluid restriction. That's the most important thing you have to do. And then for the hyponatremia, what can you do? You can give salts. Then now you can give the loop diuretics. We know that the loop diuretics, where sodium goes, water follows. So to decrease the amount of fluid. Hypertonic saline, yes, good. This one will help to correct the hyponatremia. So that's okay. And then any complications, if they ask, complications this patient may face, complications of SIADH. CCF, altered consciousness, yes. Raised ICP, yes. Raised ICP, yes. Neurological symptoms, confusion. So these are the, this is the hyponatremia. Seizures, muscle weaknesses, yes. There are quite a lot. Yeah. So what we usually, the high thing is, so raised ICP, so because of the cerebral edema and the confusion, the muscle weaknesses because of the hyponatremia, chronic heart failure, yes. Yeah, so those are all the complications. So I think for SIADH, we are clear. So this is just a summary. Etiology, so we have CNS, we mentioned drug, lung diseases, active HIV, ectopic ADH, which I mentioned, small cell lung cancer, chronic pain or nausea. Clinical features, I think we mentioned it. Then signs of euvolemia, you see I said no edema, moist mucous membrane, no jugular venous distension. Lab findings, hyponatremia, so serum osmolality will be low, urine osmolality greater than 100, urine osmolality be high. Management, fluid restriction, as I told you, plus minus salt tablets, hypertonic saline for severe symptomatic hyponatremia. Then this is basically a high-yield thing that you should remember. So in case you're given serum osmolality or urine osmolality, you know that SIDH serum osmolality must be low, urine will be high, diabetes insipidus, high, low, and then this one, primary polydipsia, serum osmolality is low, urine osmolality is low. So primary polydipsia is the one I was telling you, the psychogenic polydipsia, the people who drink lots of water. Yeah. So I think everyone has understood. So if you brought any question on renal pathology related to clinical chemistry, I think that's clear. I hope that's clear. So we can start with this one. So a 26-year-old female, look at the age, presented to a gynecologist with a history of not ever having had any menses. Number one, what further history is relevant? So yes, which history will you ask? First of all, what is this? This is primary amenorrhea because of the age. Then history, so I've given you one, family history. So if you ask if there's history of delayed puberty, what other history will you ask? What other questions will you ask as the gynecologist? Drugs. So if there's any use of contraceptives. Normal physical appearance of the female. Yeah, so basically this is height and weight, isn't it? So we want to inquire about the height and weight. So which medical condition are we inquiring when we ask about the height and weight and the growth pattern of the of this 26-year-old female. Which condition are we keen of asking? Cancer. No, it's not cancer. Turner. Yes. Turner syndrome. 45X. Oh, Turner syndrome. They usually present with primary amenorrhea and very short. They're usually short in stature. Yeah, I'm seeing you got it. So number one, family history. Ask if there is history of delayed puberty, hormonal disorders, or genetic conditions. Use of contraceptives, e.g. birth control pills or intrauterine devices. Medical history, e.g. PCOS, polycystic ovarian syndrome. Lifestyle factors. So for example, smoking, diet, alcohol consumption, growth and height, which I was saying. Turner syndrome is strongly associated with primary amenorrhea and characterized by short stature. Yes. 2 relevant biochemical tests to be done in this patient with primary amenorrhea. Sorry, when you say ultrasound, is it a biochemical test? Yes, so we do hormonal profiles. Yes, so hormonal profiles. So now, which are the relevant hormones we are targeting? Like which hormones are we going to test? For ultrasound, no. So we have the first one, FSH and LH levels, yes. Another hormone, prolactin, yes. Thyroid, I'm not sure whether do you mean TSH or do you mean T4, T3? I don't know. So maybe you can clarify. Okay. So so the first one, FSH and LH, low levels reflect a dysfunction in the hypothalamic pituitary ovarian axis, while high levels could reflect primary ovarian failure. Okay. Estrogen, low levels reflect ovarian dysfunction, which could show primary ovarian failure. Gonadotrophin release hormone releasing hormone. Low levels indicate more of a hypothalamus disorder, yes. And then prolactin. We know gonadotrophin hormone releasing hormone acts to release FSH and LH. So you can imagine this one is in the hypothalamus. If you check the FSH and LH, you're checking at the anterior pituitary level. Then prolactin, high levels may warrant looking for pituitary tumor such as a macroprolactinoma. Yes, so these are the 1, 2, 3, 4, 5. The 5 biochemical tests to be done. Okay, I can see it's 9, so